I'm discussing new approaches in MPNs and break my talk down really into three segments. One, I think as a field we continue to look, should we be treating patients earlier in their disease arc than we have currently? And that's even with existing therapies, whether it's anagrelide, whether it's interferon, whether it's hydroxyurea, whether it's ruxolitinib, but whether we should be treating patients earlier with myelofibrosis to avoid progression, earlier with P-Vera to decrease burden, and earlier in subsets of patients with ET that may have higher risk. Second, I focus on the class of JAK inhibitors. We're 5 years out from the approval of Ruxolitinib, first in myelofibrosis and polycythemia vera, and there is yet not a second approved JAK inhibitor, but there are several that are jockeying for that position, including Fedratinib, that we'll be reviewing the data here today, but shows promising results in individuals with refractory or intolerant to Ruxolitinib myelofibrosis, and in individuals with marked thrombocytopenia. Two, there's an agent that had been tabled for a while, Fedratinib, that had a successful phase 3 trial, the JAKARTA study, and even a second-line study. There had been some initial concerns regarding neurologic toxicities. I think that has been largely resolved and may well be moving forward. And finally, Myeloproliferative, that we earlier presented this year data from 2 phase 3 studies showing beneficial results for splenomegaly symptoms and perhaps anemia. And then finally, touch base really on new therapies that haven't really been tested before. There's interest in the Nutlin inhibitors that work on the p53 pathway that have shown some preliminary activity in polycythemia vera. There's interest in combinations with PI3 kinase inhibitors along with Ruxolitinib that are showing some results. There's interest in agents such as luspatercept that potentially are direct stimulators of erythropoiesis in patients who have anemia with myelofibrosis. So it's an exciting time, but it's not only about brand new drugs, but it's also about how do we more effectively utilize some of the drugs that are already available or some of the drugs that already have had some extensive vetting. It's an interesting dynamic with the JAK inhibitor space, that there were multiple agents that showed benefit and they all ran into some issue, whether it was related to some aspect of toxicity or even lack of clarity in terms of the appropriate goals of therapy between the regulatory bodies and really the medical community and the producers, the pharmacologic sponsors of these various studies. So overall as a class, it's a class of drugs that's been pretty active. And I think as we see that there is a significant number of individuals who have been treated with Ruxolitinib, there really is a strong need for more agents available. If chronic myeloid leukemia has been a prime example, multiple agents in the same therapeutic class, such as the TKIs, has been a benefit to patients. Imatinib is a great drug, but patients by CML have really benefited by the availability of nilotinib and dasatinib and bosutinib, and even ponatinib. Similarly, we hope that patients with MPNs will have more than one option. Navitoclax is one of several agents now that really are looking at these patients that are post-Ruxolitinib, have either been resistant or intolerant. Now there's a lot of discussion what is resistance or intolerance to myelofibrosis for Ruxolitinib, and in an era with only one approved drug, resistance or intolerance is a little bit in the eye of the beholder. But based on activity of Navitoclax in other myeloid illnesses, as well as some preclinical information, we're hopeful that phase 2 study will be successful. Our institution is participating with that study.